So this figure indicates the basic treatment for glaucoma subtypes. So I will talk about of these glaucoma subtypes from this. In the developmental glaucoma, we will do the glaucoma surgery in the early onset of developmental glaucoma. And the late onset of developmental glaucoma, we often do the medication, and after that, we will do the surgery. And the primary glaucoma, open angle or normal glaucoma, we will do the glaucoma medication at first, and after that, so we will do the glaucoma surgeries. And angle closure, the PAC and PAC-G, we will do the glaucoma surgery and medication. In the secondary glaucoma, in exploration glaucoma and traumatic glaucoma, we will do the glaucoma medication and the glaucoma surgeries. And these secondary glaucoma, inflammatory or neovascular glaucomas, we will do the appropriate primary therapy for the original diseases, and after that, we will do the combination of the medical and surgical therapies. The first, developmental glaucoma. So, at first, in the early onset glaucoma, so usually the patient have anterior segment dysgenesis at birth. Of course, depending on the quality of the cornea, we will do the goniotomy like this, or trabeculotomy in these eyes. In the late onset developmental glaucoma, so usually the patient have a mild angular abnormality. So in these cases, we also do the trabeculotomies. If we can get the good IOP controls, we will do the continuous observation with the medications. However, we cannot control the IOPs. We will do the additional medication or surgical treatment like trabeculectomies. So this is the developmental glaucoma. So next is the angle closure glaucoma. So in these Asian countries, there are many angle closure glaucoma patients who visit the hospitals. We make us, so these are subtypes of the primary angle closure glaucoma. PAX is a narrow angle. However, no IOP increase, PAS, and no glaucomatous optic neuropathies. So this patient indicates appositional closure of the angle. PAC, PAC, primary angle closure has a narrow angle with IOP increase or PAS. However, no glaucomatous optic neuropathies. And the last stage is a PAC-G. So in these stages, so narrow angle with IOP increase and PAS and glaucomatous optic neuropathies. So excuse me. Oh. Sorry, that doesn't work. So excuse me, the slide doesn't work. So I want to move to the next. Okay. Oh, working. So this is another subtypes of PAC. So it depends on the pathogenesis of angle closure. The first is a relatively pupillary block. So this is the most popular cases in the PAC. The anterior bowing of iris and shallow anterior chamber. And the next is the proto-iris configurations. So these eyes with steep narrow angle at iris root but deep anterior chamber. And another factors to induce angle closure, lens factors, abnormal lens position and intumescence cataract may induce the narrow angle. Also, colloidal factor is quite important. Anterior movement or swelling of ciliary body by ciliary colloidal effusion by the inflammations. So this is a PAC image by the ultrasound biological microscope. The upper is a pupillary block. In the right rooms, the angle is still open, but in the dark rooms, the angle closed. And also in plateau iris, in the dark rooms, the iris root closed the trabecular meshwork. So we have a lot of variations of these configurations of pupillary block and plateau iris. So this is a scheme of PAC or PAC-G treatment. So we need to find the mechanism of angle closure. If the patient, the eyes have a pupillary block, we will do the laser iridectomy. But if it doesn't work, we will do the peripheral iridectomies. And in the plateau iris, laser iridotomy doesn't work. Laser gonioplasty may be better. And also, periodically, we will often use a myotic agent, but not permanent. However, we have a lot of lens factors, including pupillary block and plateau iris. If the patient have an indication for the lens extraction, we recommend to lens extraction in these mechanisms of the angle closure. And sometimes patients have ciliary body swelling. In this case, we'll do the anti-inflammatory treatment for the patient. So this is a scheme of primary angle closure treatment. So next, we'll talk about primary open angle closure glaucoma or normal tension glaucoma and secondary glaucoma. So in these subtypes of glaucoma, at first we will try the medications. But if we cannot get a good IOP control, we will do the surgery. So please think about, so can we predict IOP after the surgery? The pressure after the surgery may depend on the pressure of the tissue from which aqueous fluid is drained. The original pressure in the anterior chamber is 20. If we will do the canal surgeries, the target pressure will become 15 millimercuries. And if we can successfully drain the aqueous fluid into the subconjunctiva or Tenon's capsules, so maybe the pressure become quite low. Also subchoroidal space and orbital space, so maybe the original pressure should be 1 digit. However, there is a limitation to lower pressure after the surgery. So because excluding Schirm's canals, the tissue which the aqueous fluid was drained should be almost zero at first. However, final pressure is modified by the resistance increase by wound healings. The risk factors of the resistance, the increase of resistance is tissue damage and scarring. And the second is aqueous fluid component. Also, conjunctival condition is quite important. If the patient using a lot of eye drops, the result of the filtration surgery is a little bit poor compared to the intact eyes. So anyway, keep drainage to flow aqueous fluid is anti-biofunctional for the eyes. So that is a problem. So we need to fight to reduce these complicating factors to get a good final pressure. So what do we select for the glaucoma surgeries? The indications of glaucoma surgeries depends on the glaucoma subtypes and the target pressure.